Welcome to the Low Carb Conferences podcast. I'm your host, Dr. Jeff Gerber. And today our special guest is Dr. Karam Nasir, and he'll be speaking at our conference in February. So how are you today, Karam?
I am fantastic, Jeff. Thank you so much again for the kind invitation, not only for the conference, but today to really deliberate and share the thoughts, and more importantly, getting your feedback, as well as on the conference. We'll have our audience chime in on really this challenges journey, I would say, that have shaped our understanding on the critical role of atherosclerosis that gets merged with risk assessment, management, and diet, and especially this phenomena that I'm sure that's well popular, the power of zero, absence of disease that has shaped the past, present, and future, and more importantly, what's its role going to be in CV prediction and management.
Yeah, well, we'll get into that, and it's great to have you. And just to introduce you to the audience, Khurram is a preventive cardiologist and researcher. He is the chief of cardiovascular prevention and wellness at Houston Methodist Hospital and professor of medicine at Weill Cornell Medical College. He's an associate editor for Circulation, the journal, and is on the board of directors for the American Society of Preventive Cardiology. He's well published in the literature with over 500 papers, and he lectures all over the world. His particular professional interests include coronary atherosclerosis, non-invasive cardiac imaging, including heart calcium scores, nutrition, and prevention. In addition, he's very active on social media, including Twitter. So, Karam, if you can provide us with a little more background and tell us about your personal and professional interests.
Yeah, so just to be short, I was very fortunate to land on the shores of US almost 22 years back, really not having a clear idea what I wanted to do, but of course, engaged and got interested in cardiovascular prevention epidemiology at Johns Hopkins, where I did my MPH, and working with Roger Blumenthal, initiating the Chicroni Center, all of us working together, which has really become the Mecca of preventive cardiology. And extended my interest into the imaging with a fellowship at MGH and cardiac imaging, and then outcome science at Yale, where I did my cardiology fellowship, heading down South Miami to develop a preventive cardiology population health program. That's where I got more interested into the role of big data, population performance management. And then now coming, thankfully, after so many years, in Houston for the last 3 years, to initiate and taking all the lessons learned and how can we create a most comprehensive cardiovascular population program, not as a boutique clinic, but really for the masses. And thankfully, over the last 3 years, we have gone extensively to a point where we have almost 5,000 preventive evaluations and management visits, a lot of familial hypercholesterolemia, coronary artery calcium testing is a big part of us. So apart from wearing a lot of these hats, true to the cause is how do we take all those that we have learned, new knowledge generated, in applying that in the real world to our patients. And I truly still remain a very active clinician, seeing almost about for two and a half days, about 60 to 70 patients a week, almost about 2,000 patients a year. So, and that's really where we get our, I would say, inspiration, and what more importantly, getting a pulse of what is truly needed by our community and our populations.
Yeah, great. Well, you've worked with many of the famous cardiologists, including Arthur Agatston. Can you tell us a little bit about that relationship?
Well, I can tell you, if it wasn't for Arthur, I don't think so you and I will be speaking today. You wouldn't have invited me. Honestly, getting inspired by his novel insights way back in 1990, by the way, when he first gave us the clues of atherosclerosis as something to pin on our CV risk and management, I can tell you that the big guns, AHA and ACC, kind of rejected that notion. And you will be surprised that his first abstract now of the paper on the calcium score got rejected by AHA almost about 33 years back. Again, I would say hindsight is 2020. But not only being inspired in my academic and research interest and now taking that to the population, I was extremely fortunate to work closely with him for almost 5 years in his preventive cardiology clinic when I was in Miami. And I can tell you that truly gave me the view, the broader view, which I think so we all have a siloed approach where he was able to take almost everything together. The patient as a whole, the lifestyle, nutrition, risk factors, biomarker, imaging, and truly coming up with this idea that no two individuals are the same. And how do we get to a point where we treat the right patient with the right intervention in a personalized fashion at the right time? And, kudos to him. I don't think so there are many preventive cardiologists of his caliber that are able to do that. And I'm hoping that he would visit the Low Carb conference sometime to engage the audience and everyone else. And in his honor, I've started a preventive cardiology fellowship because I think this is a dying art. And I want to make sure that we can pass on the baton to the next generation, training them in the comprehensive approach, which is extremely limited in our general cardiology practices.
Yeah, so look, we walk on the shoulders of giants, and I think you're the next giant, Khurram, and that's why we're having you at the conference. And Arthur did speak in 2020, although it was virtual, and we hope that we could get him in the audience and some of the other cardiovascular preventive healthcare professionals to join us. And so, your topic for the conference is going to be what's the latest, greatest on calcium scoring. But I thought for the audience today, we might kind of back up and give us a little history and to talk about cardiovascular imaging in general in the realm of prevention.
So, Jeff, I would take a step back further. Why are we even having a conversation around cardiovascular disease? Honestly, if you and I were back almost 80 to 90 years ago, I don't think so this would be on our top to-do list. Really, I'm 47. I would be thinking that I've reached my maximum lifespan, and that was the average age. But again, kudos to public health and introduction of sanitation and TB pneumonia control. We overcame those challenges, and post-World War II, we slowly started to seeing this new phenomena that many young individuals in their 50s and 60s, especially men, having heart attacks and then dying from them. So that's really where I think this whole cardiovascular prevention, imaging and everything is such a newer phenomena, and where we have started learning more. So, but since the introduction of the heart disease and initiation of Framingham Heart Study in 1948, of course, spurred by the death of FDR, and with this new CVD phenomena, this concept of who is at risk and how much are the risk is a conceptual framework that has gained so much significant relevance as we speak and deliberate, not only in cardiology, almost everything, but more so when we're talking about prevention, which I believe is the foundation of our management, depends upon this very one simple question, yet very meaningful. So again, prevention's broad. Of course, you have patients who have now established cardiovascular disease, and of course, the horse has left the barn, but we still have to work with them. And I feel that at least, and then again, that could be a separate topic for discussion. In my view, at least, there is little debate on that they are relatively at an elevated homogeneous risk above a certain level, and hence the degree of benefit with more intense management. And of course, that not only includes pharmacotherapies, but also lifestyle interventions has translated in huge gains and reduced recurrent events and mortality. Now, the challenge as a cardiology community and all of us are facing is extrapolating the same strategy of let's treat everyone with the same degree can be very challenging in primary prevention settings where majority of the folks have not yet declared with an established heart disease. And four big challenges. One, the risk is pretty homogeneous. And of course, we can discuss a little bit more, like no two individuals are alike. We're dealing with a very large population. Almost 90% of the adult population does not have a diagnosis of an established cardiovascular disease. And it's now not only about lifestyle choices and pharmacotherapy choices, but also the intensities of management. And then if I put in on the hat of the health systems perspective and population health and a payer's perspective, how do we best mobilize our resources, attention as physicians, and focus? Who needs it at the most at the individual and the societal level? So that's where I feel the imaging has come along a long way, especially over the last 2 decades, in trying to make us more efficient, into the point that we can dedicate our resources, focus on the people who truly are at risk, whereas having more flexible lifestyle, dietary, physical activity, weight, smoking cessation, interventions among those who are at the lowest risk. So we can, I would say, gain the yield from our efforts the most.
Yeah, so I know you had pushback on imaging way back, and I guess it's still frustrating because if you look at the guidelines, thank goodness they now have included calcium scores, but the idea way back when was just we need to do blood markers. So all we do is get blood markers, and that will give us a picture of our cardiovascular health. And so what is it about the imaging that gives us additional information that we don't have from blood markers?
So, I'm just going to take a step back a little bit before coming imaging. So why blood markers and risk factors? Since our quest started in the late 1940s and early 1950s in predicting mechanisms, we have always relied on assessments on blood pressure, cholesterol, lifestyle factor, health conditions, diabetes, which are known as risk factors. And by the way, the term was first introduced in 1961 by the famous Framingham Heart Study, when they identified that. And to date, I think so that's what we have done, because if you look back, when the National Cholesterol Education Panel guidelines in 2002 came in, and the focus was restricted statin allocation, and then 10 years later, the pooled cohort equation in 2013, it's still a risk factors biomarker approach. So that still remains the rule of the land to date. But I think if you look at over the last 50 years, it's not unfair to suggest that from an innovation standpoint, we have stalled. And our imaginations have really stalled. And the only thing we have done is taken the same ingredients, the same risk factors, shook them up a little differently, and came up with different mocktails. And, one can argue that, we don't have to do things differently for the sake of it. But more importantly, do we really need newer approaches? And for that, how are the risk factors working? So if you look back in the early 2000s, the risk factors approach, and we all agonized on that we were truly struggling in identifying the true higher risk individuals, because the approach was more limited. Then overcoming the original sin of really limiting individuals who should be considered high risk and managed accordingly, the pooled cohort equation opened up the doors for the statin island and overcrowding it to a point now we over-predicted a lot and were asking too many people to get on statin. Now, I think that, and I've been a firm believer with Arthur and many others, that our risk factor paradigm are primed for a dramatic makeover, and we've been advocating for almost now 20 years. And of course, we have a richness of choices where we should focus on. And, this just reminds me of Willie Sutton when the journalist asked him, why do you rob the banks? And say, why? That's where the money is. And I think so. Imaging and atherosclerosis has this application here because atherosclerosis is the true disease and a reflection of your accumulated risk, but also if you're talking about a palantary or a crystal ball looking into the future, may provide the greatest opportunity. And this is what Arthur started almost in 1990, but it took us almost till 2009 when we finally, at least from an evidence standpoint in US with multi-ethnic study of atherosclerosis and Heinz-Nixdorf showed that calcium testing is the strongest predictor of who is going to be at a risk. For example, 9 to 15-fold higher risk. Now, you and I know in the early 2000s, we used to think diabetes is CVD equivalent. Truly, they're only 2 and 3-fold higher. So not only identifying the higher risk, but in 2009, we also came up with this novel concept of power of zero as residents. And we thought that, why not look at upside down? What about a lot of individuals who may not have any disease, and the evidence that we accumulated and in a prospective study, we showed that there are such a low risk that we can potentially forego a downstream expensive imaging. And for the first idea on the flexibility of preventive therapies, I can tell you there was a lot of pushback, and almost all the major journals didn't think that was an idea worthwhile to pursue if it wasn't for Dr. Fuster and Dr. Narola, who published our paper simultaneously in JACC Imaging and now cited more than 1,000 times. And at that moment, honestly, Jeff, I had no idea that this concept would lead to a wonderful journey of discovery, impact, and also tremendous resistance, because the first resistance that we got that, well, if you have a lot of people with risk factors like dyslipidemia, which we believe is atherosclerosis or higher inflammation and risk factors, they're less likely to have any low calcium score or a power of 0. But even if they have, who cares? So, and then again, it was an evidence-free zone, and we went back to the drawing board. And among the many papers, one I want to highlight was done by Seth Martin from Hopkins in 2014, which got published in Circulation, that showed that your true risk is mainly mediated by the amount and the burden of calcium scores. And even among individuals who, by traditional parameters, if they had abnormal LDL, low HDL, and elevated triglycerides, who we would think are higher risk, almost half of them didn't have any plaque or calcium scores. And then about 40% of individuals who traditionally will think are not dyslipidemic had disease. But when we looked at the outcomes 10 years, it was truly dictated by the calcium scores. For example, you may have the highest levels of the LDL and a calcium score of 0. Your risk is much lower than somebody with the lowest amount of LDL, but just minimal plaque. And it didn't matter. You could look at the non-HDL, lipid particle size, and now there's a recent paper that's just got published this year also with the lipoprotein A. And you could slice and dice it any ways you want: inflammation, meeting criteria for Jupiter, multiple risk factors, family history, aging. The answer was the same. So in 2015, we took this concept that now we know that calcium predicts individual at higher risk. There's a lot of people who would be unnecessarily treated if they don't have a plaque. And we found that that's true because in our US journal representative population, about 40 to 50% who we would think, or the guidelines would suggest that let's have them commit to a lifelong statin, had no plaque, and they did pretty well. And we showed that no other biomarkers, you can do a carotid IMT, BNP, CRP, even a healthy lifestyle, didn't really de-risk as much as a calcium score of 0. We also showed that it was a cost-effective from a societal perspective, this approach by doing calcium score and treating only if you have positive. And then a great study from colleagues, Joshua Mitchell and Todd Villanis from the Walter Reeds, showed that in a 12-year follow-up, if even a large population who were treated with statins and had a calcium score of 0, we didn't see any differences. It was truly the differences were noted if you have a calcium positive, and especially a high burden, more than 100, where all you needed to treat 11 individuals. Now, with all of this information coming out in 2017 till 18, finally, the guidelines for the first time acknowledged the progress. And they also made recommendation that even if you're considered for statin and you're uncertain, like most of our patients are, you can do a calcium testing. And if it's a calcium score is 0, you can forego and be flexible and focus more on lifestyle interventions. Now, Jeff, that's a big moment. Now, of course, as cardiologists, we're the community that didn't believe in the lipid theory. Then we went completely on the lipid theory, and now coming back slowly. If in 5 to 10 years, we have an opportunity to reflect that, I think so this will be the pivot where, as a big shift, our cardiology community startly shifting from risk factors approach to see disease and treat disease. Now, we had made progress, but also we had a lot of challenges, and I can talk about that. The honeymoon really ended in 2009, but after that, there has been still a lot of pushback, and we can discuss further based on what you think are the areas we need to focus.
Sure, Khurram. Well, I did not realize that it was you and your fellows back in 2009 that coined the term the power of zero. I only learned about it recently in the last couple years because the guidelines basically say now, and to credit to your group, that if you have a calcium score of 0, it's a decision point in terms of focusing on lifestyle and diet. And then all of a sudden, I started to hear about the power of 0. And so that's a fantastic story about, you know, how we got there. And, you know, I wanted to bring up some of the recent studies from the Western Denmark Heart Registry, you know, Mortensen et al. And I'm sure you're familiar with them. And what's fascinating about their work is that they basically looked at a population of 24,000 who were symptomatic, and I think they went in for CT angiograms. And my question is, I've looked at some of the papers. What are your comments, and how does that affect this power of 0 issue?
Well, since you mentioned that it was recent that you learned about power 0, I can tell you that two things. Of course, we didn't have Twitter in 2009 to 14. And I really attribute the concept of the power of 0, or the hashtag power of 0, gaining such a momentum and recognition to Roger Blumenthal, because when he presented the guidelines in 2009, he had the hashtag power of 0 and said power of 0 equal to a decision aid. So I think that's really where the concept grew up. Now, you know, as I said, over the last 3 years, we have been struggling from multiple areas. One is, of course, we still have a very vocal, contrarian and lipid-centric group that's pushing back and saying it's all about lipids, all about risk factors, and power of 0 is not forever, like diamonds. And, you know, it's a good slogan, but you have a blind spot. And then on the dramatically opposite end, of course, I'm a big fan of CTA, and I think so it's teaching us a lot about the biology and progression and initiation of the disease, who are saying it's all about the non-calcified plaque. And then folks would come in and say, well, the younger individuals, the calcium has not yet set in. And if you're going to be flexible with the power of 0 in the long run, you may be missing a lot of individuals who could have benefited. And what about the non-calcified plaque? So a lot of challenges, but again, you know, and many red lines have been formed: young, non-calcified, severe hyperlipidemia. But I think so it's great because people are bringing up these issues, but that allows us to clarify. And I ask all of us to stay clear of sentimentality and let's focus on the evidence. So let's talk about Mortensen data. So in essence, what they did, as you pointed out, 20,000 plus individuals who had CTA. They also looked at the calcium score, and then they looked at the spectrum of age, like less than 40, 40 to 50, 50 and above, 60 and 70, and asked the question, what was the rate of obstructive disease or significant disease if you had a calcium score of 0 on CTA? And they also looked at, among people who had obstructive disease, how many had a calcium score of 0? Now, my thought about this is, you know, if you ask the wrong question, you get the wrong answer. And that's what most of the folks have latched on to. And the question, and that's what I think, so the tweet from JAMA Cardiology, which I think it's kind of not accurate, and saying majority of individuals who are young, who had obstructive disease, had non-calcified plaque. All right. So if the question was, Jeff, if your question was that among patients, young patients who present with obstructive disease, how many of them have a calcium score of 0? Yes, of course, the more younger, the higher. So about 50% of them have it. But the true population value, and more importantly, is when a patient walks into my clinic or your clinic and is young, and we do a calcium score testing, a calcium testing, and if they have a 0, what is the likelihood that they will have obstructive disease or meaningful disease? Now, that's the true question. Now, if that's the question, then the ability of a calcium score of 0 to rule out meaningful obstructive disease was similar, 97% negative predictive value, as it was for a 60 to 69-year, actually higher, which was 94%. And they have provided that data. More importantly is the other question is, what is the risk of having an MI in this individuals? Can it rule out an MI in the next 4 to 5 years? And that was 99.5%, almost similar. So in essence, if the issue is that is calcium testing and calcium score of 0 reassuring in the young, the answer is yes, because it has the same negative predictive value that it would be for an elderly. And even if they have obstructive disease, their event MI is much lower. And I've learned from Arthur that it's not about just stenosis, it's about the plaque burden. And in a calcium score of 0, if you have non-calcified plaque, now we have done a study, a population-based study in Miami, where we recruited 2,500 individuals, younger individuals, age 40 to 60, mean age about 50. Yeah, about 15% have exclusively non-calcified plaque. And that's consistent that what we have known from symptomatic and the rest of the literature, but majority of them is a streak, just in one. Now, is that meaningful? Is that adding, I would say, information by an inch or a mile? We do not know. So from that perspective, I think so that the power of 0 has been significantly well demonstrated in the symptomatic world. For example, in Scott Hart, if you had a calcium score of 0, your risk was almost similar if you had any other plaque. In a large study that was done in UK, where they took more than 5,000 patients, half of them had a calcium score of 0, ruled out obstructive disease, followed them for 13 years, almost no events or no CHD death in the next 13 years, where they, as an authors, question the value of doing anything above and beyond the calcium score of 0. So in essence, as I said, it's complicated, but that said, the data is extremely reassuring, and it all depends which lens you're looking for, because if your goal is among people with obstructive disease, how many had a calcium score of 0? That's well documented. We know younger guys, the obstructive disease and MI is very rare, but if it happens, it's going to be exclusively non-calcified plaque. But if you want to reassure a 45-year-old individuals that you are less likely to have meaningful obstructive disease, the calcium score of 0 will give you the same information than it would be for a 65-year.
Yes, well, that was a lengthy explanation, Karam, but yeah, thanks for discussing that. And so I was a bit confused when I was looking at the Mortensen data. And as you said, the study has to ask the right question, and I guess it's more in context. And so their work was, purely looking at symptomatic people that came into the emergency room, whereas you're describing in the setting of prevention, the role of the power of 0 in the calcium score. So thanks for clearing that up. And, there's still going to be debate about where we're going to head in the future. So, one thing I like to do with my patients, and tell me if you agree, is I like to describe the benefit of doing calcium scores versus doing blood work. And so, for our population, we generally recommend it in men over 45, women over age 50. But I tell the patient that the calcium score is a direct visualization of the disease process itself. And you're not really going to get that with blood markers. And the analogy is that blood markers tell you about the quality of the fuel of the gas tank of an engine, whereas a calcium score, you're looking at the gas tank itself and looking at the health. And they get that right away. How do you like that analogy?
Not much different, almost similar to what we describe, and our descriptions. Look, these are risk factors, and yes, they may track, but at an individual level, there is a lot of, and we disclose the heterogeneity that you may have the worst lipids and have no disease and vice versa. And we have tried in the past and trying to find out how that can predict. And we have kind of, I would say, failed, and really coming to a point and saying, why do we want to do more expensive tests or biomarkers to identify those who are at risk, where you can get this test for $55 to $150. It takes about 2 to 3 minutes. The radiation is equivalent to a mammogram that most of the women. And once you detect calcification, or it helps you understand where you are on this trajectory and what options and what intensity. Whereas if you don't have it, bless your stars, more focus to a wake-up call to focus more on lifestyle, so we keep you that way. And I can tell you that almost the general public is very sensible. They understand the value. We have never had any issues in having them to agree to do this. And actually, they are pretty surprised that why it's not as widespread when they saw their primary care or other cardiologist, and why no one else is bringing it up. And also the issue is why it's not covered by insurance. And, it's just a long, challenging journey, but we are seeing that it's getting much more adopted than it was 3 years back, but we still have a long way to go.
Yeah, it's frustrating to me that the U.S. Preventive Services Task Force still do not recommend heart calcium scores, but they're pushing colonoscopies.
Well, it's challenging from their perspective. They still are in the mindset that this is a screening test. And from their perspective, unless and until there is a well-designed study that demonstrates that individuals who underwent calcium testing, there is a reduction in MACE and or mortality as compared to who didn't. And they're not thinking broadly as a shared decision-making tool where we are really flying blindly without it, and may put so many patients on medications that may not need it, and vice versa. So I think so that there is definitely room for further improvement dialogue. I'm delighted that at least at ESC and the New England Journal from Denmark, we saw the first interim analysis where individuals who underwent a comprehensive cardiovascular assessment, including calcium testing. Based on that, management was intensified with statin and aspirin. In elderly men 65 and above showed a 5% mortality reduction overall, but more importantly, in the youngerish adult elder individuals 65 to 70, we have seen an 11% reduction in mortality. We saw almost similar reduction in MACE. Thankfully, a lot of criticism is that the calcium testing may generate or significant downstream interventions, CATs. We didn't see that. And they also published a cost-effective analysis saying calcium testing and this approach paying for 200 euros, which was the cost for that. It's extremely cost-effective and actually maybe slightly more than for some of the cancers. So, Jeff, I think so the future is bright. We are having more data. I think so there is a much more understanding, but of course it will take time to overcome these dogmatic obstacles that have been there for 2 to 3 decades.
Yeah, so just for our audience, MACE refers to major adverse cardiovascular events. Just wanted to throw that in. So yeah, well, look, we appreciate the value of doing screening. And so, for our patients, as you know, I'm a family physician. We don't necessarily recommend any additional intervention after getting calcium scores, even high scores. And so I have a lot of individuals that take the deeper dive in, and they want to do follow-up CT angiograms. And so maybe we should just do CT angiograms on everybody. I'm just kind of throwing that out facetiously because I know that, in terms of populations, that's really not a cost-effective approach. And then there's additional radiation. But what do you do with patients who have higher calcium scores?
Right. I think so. Individuals who don't have calcium, power of 0, that's pretty straightforward. Focus more on lifestyle interventions. Repeat the test in 3 to 5 years, depending upon which spectrum of the risk they are, to understand whether they continue to retain the power of 0 if there is any minimal change, so we can start having a conversation. Now, individuals with the high calcium, it's a challenge because although as a group, about 20 to 25% are at a high risk of having a heart attack, stroke, or dying from it in the next 10 years. A majority may not have. Now, is CT angiogram the answer? I think probably. By the way, I'm a big fan of CT. I think so. It has given us so much information on detailed architectural phenotype on the plaque characteristics. So helps us understand the initiation progression. And I remain bullish. But at the same time, I think we need to take a step back and think, where would its application be? Now, if the whole idea is that we want to take prevention, and the foundation of prevention is who is at risk and what your risk is, and you need a tool, the widespread adoption is going to be a challenge. And Jeff, I don't think radiation is going to be an issue. And I can tell you, I was in Pakistan and I had two individuals. I took them myself. One got a CT and one got a calcium score. And that whole experience thing is getting an IV, beta blocker, nitro, 35-minute exam, all that process, 3 to 4-fold higher cost, versus calcium getting done in 5 minutes and giving me almost the same answers from a management standpoint. I feel that it may not add, if we truly want to expand the role of the prevention. Now, of course, limited population, for example, familial hypercholesterolemia, young, and individuals who are uncertain about their calcium score overall, whether we can have further reclassification of, do we need more intensive management or not? A CT is an option, and I think that individuals who are willing to pay out of pocket, it's a great test. Also, we don't know so far what we have seen from prior data, that if you put in the information from the CTA on top of the calcium, for example, in the Scott Heart study, it didn't really add much. We have seen that in the confirmed registry, which is one of the largest registry of symptomatic, asymptomatic, and the asymptomatic population, it didn't have. However, whether there is some value in a certain population, we are doing the study in the Miami Heart study, where 2,500 individuals have been recruited, both got the calcium and the CTA. And Jeff, by end of 2023, we'll have a 5-year follow-up. So we'll be able to answer more. I think so. I'm agnostic. I'm definitely bullish about its value in understanding plaque. But from a population, health system, patient, and maybe even a physician level, I feel as far as risk assessment, it may not add much, but, I'm very happy to come back in a couple of years with newer knowledge and say, I was wrong, and maybe this is the way to go.
Yeah, so we are selective. We do send people for angiograms. And I know there's a group now in town and nationally that they're promoting angiograms with additional software and diagnostic testing, and they're really marketing and pushing. And I'm sure you've heard about that. And we're trying to make some sense of that as well.
I think so. I'm happy that industry, mostly folks who have been in this space for the last 5 to 10 years, leaders, imaging leaders, were coming with automatized mechanism where, yes, with the calcium, we know you have a lot of plaque, with an added plaque analysis telling us what type of plaque and potentially whether that can help refine yours and my assessment of risk and management is yet to be seen. But Jeff, where I look at the future, I think so that most of these softwares for plaque analysis eventually with rapid growth in the AI space will be part and parcel of the scanners at some point. So whenever we do a CTA, we'll get those. The question where I think that we need to push the envelope is, with more AI and machine learning, can we extrapolate some of those features or insights that we get with the non-contrast CTA, with the simple non-contrast calcium score? I think so that's where the money is. But the future is bright. We're having a lot of innovation. We'll learn a lot, and hence help our stakeholders, the patients.
Yeah. Well, very good. I've been burning to ask this question. So We have several CT machines here in town. And up in Boulder, we have an old EB CT machine. And that's kind of hard to find places to do that. They're running out of parts. It was originally from General Electric, and they don't produce that anymore. So most of the machines here in town are the 64 slice variety, but we have a couple 256 slice machines, and there's one right down the street from us at the Cardiology Center. And we've been having some difficulty with correlation between the 64 slice and the 256 slice. In fact, the cardiology facility, they used to have a 64, and we can't compare numbers, and specifically it's the volume scores and in cubic millimeters. And so what we're finding is that we're getting substantially different readings on the volume scores with the 256 slice machine, so it doesn't correlate. So I'm telling patients, look, go to the same facility. But the thing is, it's supposed to be comparing apples with apples. So my question is, what exactly is going on?
So Jeff, if you think about it, all you need is a 4 to 16 slide at the most, and it all depends upon the technology about the slice thickness, right? So traditionally, you need a minimal of a 3 millimeter slice thickness. Of course, if you start going into a thinner slices, you have more images, and we may see even more individuals who had a calcium score of 0 that may turn out positive. Now, if I take the same patient, and let's assume you had a calcium score of 60, I'm just throwing out a number, and I repeated you on the same scan, same machine, there is going to be a 10 plus minus variation. So your score may go up down to 50 or maybe a 70, depending upon where the slice thickness and cuts were on the first machine. Now, if I take you to another machine, it may range almost in the similar or slightly wider. Now, my take on that is, does it really matter? The key matter is, if a calcium testing is shown 0, and the other scan is showing 15 or 11 or 5, or if your calcium score was 300 and the other machine is showing 90, right? So thankfully, I know there are tons of studies, at least we have been engaged with some of those. And in real world, I can tell you that we don't see that huge variations that pushes you in a bucket that where your risk category journal average changes hue to a point where it may impact the management. So I can tell, my whole thing it's a simple test, widely available. If you want to get it with the 256 versus 16, honestly, my experience has been that at least the categories are almost similar. Now, I don't know what has been your experience. Have you seen dramatic shifts in recent years, or kind of in that smaller range that we just discussed?
Actually, the 64 slice machines, we seen pretty consistent results. It's just, this is like a, like a black swan. It's a weird thing that they go to the 256 slice machine, and it's not the the density. When you say the calcium score, you're talking about the Agatston score, the density. It's actually, we're seeing the difference in volume, and I've actually called them, and they really haven't provided an explanation. So we just have patients go back to that 256 slice, and or they'll stay at the 64 slice machine. So that's how we deal with it. But it brings up the next point. So we actually like to do serial scans, and looking at volume scores, the work of Raghi from years back, he suggested that tracking volume tells you more about progression of disease, and where density may tell you about consolidation. So do you think there's any value in serial testing?
So I can tell you, for the last 20 years being engaged in this, I'm still trying to come to terms where exactly the highest value is going to be. Paul Raji and I have worked very closely together on a lot of this, and his seminal work has shown about this whole thing about 15% to 20% change. Now, the problem where I have is that when you have low scores, so if going from 10 to 20, that's a 50% increase. Now, what is that meaningful? So I think so the absolute changes are more important when your scores are low, less than 100, because again, if a patient's coming, let's assume the score was 20, and they come back after 5 years. And of course, I'm working with them on a very aggressive lifestyle, intermittent fasting, keeping a good body weight, interval training, optimizing the diet, and of course, on a statin, no need for an aspirin, their blood pressure is well controlled. They come back and now your score is 40. What are we going to do? And their LDL is 55, they're asymptomatic. Is that a meaningful change? And, it all depends. And Arthur has emphasized, and I do that, I tend to look at the lesions. So if the lesions are getting more, as you know, you're absolutely right, the density, if they're having newer lesions, which are not as dense, then absolutely we may intensify some of that which are already done. Now, if somebody comes in with a calcium score of 100 and it goes to 350, then I'm trying to look at more, are they insulin resistance? Maybe a Kraft test to figure it out, whether we need to do more. Are we missing on the triglyceride board, whether they need icosapent ethyl more? And so some of those, but that's where it is. For me, the biggest value of a repeat calcium test is with the calcium score of 0, where in 3 to 5 years, that allows us to shift them to a point where now we're going to truly intensify treatment beyond the lifestyle interventions that we are pursuing.
Yeah. Okay. Well, thanks for addressing that. And also thanks for mentioning the Kraft test, the insulin assay. So obviously, Arthur Agatston has influenced you over the years. And we're going to leave the conversation about medication for another time. But I want to touch on our last point, the low-hanging fruit, and that is of nutrition and lifestyle. And what are your general approaches to that?
Yeah. So I think those are the central tenet of anything we do in prevention, and especially preventive cardiology. And I give the example to all my patients and say, look, honestly, if they were pills, they would have been $1 trillion business. And if you're truly interested in longevity and optimal health, that's the number 1, 2, or even 3 top one before even thinking about pharmacotherapy, because truly basic science studies, translational studies, longitudinal studies have shown that apart from plaque stabilization, endothelial function improvement, inflammation, impacting your DNA, for example, intermittent fasting, and all of those, and cardiometabolic health, that is the prime. Now, of course, working with Arthur, looking at various diets all across, be it Atkins very deeply, of course, the South Beach diet, which is very much similar to Mediterranean. If you look at the paleo, of course, now we have the new plant-based, and a keto diet. My sense of nutrition, coming on the nutrition, is that there are more similar than dissimilar, of course, on the edges. And if you do a deep dive, and I'm sure you recommend the same thing, the key principle for all of this diet is no sugar, fructose. That is the basic principle you look at in almost all the diets. Now, that's the central piece. And then you go a little bit around that, processed carbohydrates, avoiding that. Bread, pasta, rice, high fructose fruits, shifting to more processed, I would say complex vegetables, complex fruits, legumes, lentils, and in the end, smaller plates. In the end, of course, you can, some folks say that you're following a diet, so now you can eat as much and anything. And I say, look, depending upon your values, preferences, your interest, I don't really care if you go on a keto, on a low carb, Atkins, plant, as long as you can focus on these principles. Those are the key principles. So from my perspective, my hope is, rather than having a flag on different diets, trying to engage the patient and bringing in on the key principles so that they can make those changes which are sustainable. and understand those pieces where I think the cardiometabolic disorders, fatty liver, visceral, your fat, triglycerides, insulin resistance are, I feel them, they are the triggers for the fuel, which are the cholesterols that we focus a lot on the fuel, but we don't focus on the triggers. And I think so focusing on the triggers are more important. Now, this is diet and moving to the lifestyle. Intermittent fastings, I strongly recommend my patients on the intermittent fasting. I have personally seen significant improvement in their health, their energy, their weight, their cardiometabolic inflammation, and it's out there in the studies. So on this principles, then moving into physical activities. So, there are two elements, physical active and being exercise. So not being sedentary is the first step, getting these people to start moving. And I slowly, again, similar things, I encourage folks to focus on three things: frequency, duration, intensity. Trying to get them to sustainably increasing the frequency, the time they are taking to do dedicated, moderate to vigorous exercise. How can they increase the duration of that? Interval training is fantastic. And a combination, it's not only about aerobic, it's not only about resistant training, trying to get them on that aerobic and resistant training exercise. So I can tell you that with these principles, we're being agnostic on, I like this diet versus this. I think that we have a lot more buy-in from our patients. And of course, the key thing is how do we follow them? So we have a team that continuously monitor them, especially those who are not going on pharmacotherapies or intensive pharmacotherapies, which, by the way, is based on shared decision-making. A lot of patients may not want that, and it's absolutely fine. And we work with them on that.
Well, great, Karam. We are similar in that we are trying to find some common themes. And I know this is going to be your first low carb conference. And I just want to add that, we include animal protein and natural fats as part of this healthy diet, which you didn't mention. But the idea is that we want different opinions and of course your expert perspective, and that's why we're having you at this conference. And it's we actually think about relabeling or renaming it in the future as just a general health and nutrition conference rather than just specifically low carb, because I mean next year we're trying to take a broader picture to look at this. And so just to finish up, Khurram, I imagine, have you given presentations to the general public in the past?
Yes.
Yes, I figured. And so what's unique about our conference is that we have the general public and healthcare professionals. And I know that you're very technical. And so we want you to bring the studies and the technical skills to the talk. But then at the end, give a simple explanation of what you just discussed. Are you capable?
I would try my best. I try to do that with my 20 plus patients every day. So, in the end, we'll get to a point where, I personally think that the general public's very well aware on the issues and what's atherosclerosis and what needs to be done and why atherosclerosis is important and what are the interventions. So yes, we'll have a fun conference. I just want to make sure that they get the facts also to the point where it's not my opinion, because I'm a firm believer. I don't really care much about the opinion, even if it's mine, as long as we can back it with data and evidence.
Oh, yeah, that's excellent. And I was just joking. I trust that you're going to be doing an excellent job. So what do you enjoy about, going out to conferences and, spoken all around the world? What is it that you enjoy about being in person?
The three things, the one more important thing is diversity of thoughts, honestly. What I try to learn is how the experts in this space, and and honestly, I think that the patients and the general public are bigger experts because they're living with it. And it's at sometimes what I feel there is a disconnect between the guidelines, expertise, and what's happening in the real world. I feel that we have to understand where the data and the studies are, and they're focused more on that. But what's the reality on the ground? what is our stakeholders are asking? And so speaking with diverse views, and actually I love to hear thoughts which are contrarians, which do not go along with my own beliefs, because I have to be reminded day in, day out that, there's only one thing that's permanent, that's change. And I don't want to get stuck with few ideas. And those are the ones that stimulate us to go back, either confirm what we believed in or refine, pivot. Because in the end, Jeff, what you and I and all of us are trying to do is do the best for our stakeholders, the patients. And we can't keep a closed mind. So I love talking to the patients and the general public, because that tells us what's the true need. And I can tell you that the power of zero, people were doing it even before the guidelines. The physicians like you and everyone else and the public was, what's the big deal in 2019? We have been doing it, right? So, there are a couple of steps ahead than us in the top end of the academics, where it's all about the studies and everything, RCTs and everything and guidelines. We lag behind 5 to 10 years. So that's why what is the most important piece coming to the conferences like this is to hear from everyone what's the latest and where the future is going to be.
Yeah, so well said. And I agree. It's so powerful when you tell your patient you have a 0 score. It just motivates them. We want to keep it 0. We want you to stay healthy. And so it's empowering patients to either continue with what they're doing or to make positive change. So you said that rather well. So how can the audience find out more about you?
That's a good question. So you can follow me at Twitter. It's at Khurram N1. You can look at what we do. If you're in Houston and you have relatives or friends or who should be encouraged to undergo a comprehensive cardiovascular prevention, we have a website. They can look at us. And then again, the other thing is, if they want to really look at some of our talks we have on the debate, so our cardiovascular debate YouTube, you're going to find a lot of talks there on prevention and other things. But again, you can find my email on Google, on Twitter. Reach out, anything I can do to help, any questions. And of course, the key point that what I'm truly looking is, I want more questions from the audience, because that is, at the February conference, I'm going to keep my talk short, focused, and more open for discussions.
Well, great, Karam. And to our audience, if you want to hear more from Karam and our great other list of speakers, over 30, please join us in February, and you can find more information at lowcarbconferences.com. And so until next time, we'll stay in touch and look forward to seeing you in February, Karam.
Perfect. Thank you so much for having me.